So, ladies and gentlemen, please welcome to the second part of our discussion about hypochlorous acid versus sodium hypochlorite acid. As we did in the previous video, we'll be using Vashe wound solution as the prototype for the hypochlorous acid and the Anasept or Dakin solution as the prototypes for the sodium hypochlorite acid. So let's dive into the literature review about the topic at hand. So there are two papers that I was able to review demonstrating how bacterial growth is correlated to increasing pH. So as you can see in this table, let's see. Okay, it's a cursor. As you can see in this table, the growth of the common bacteria isolated in wound cultures are favored by increasing pH. So likewise, it has been demonstrated also that the biofilm production is correlated to higher pH wound environment. I would like to mention that the pH of Vashe is 5.5 and the Anasept is 7 to 10. And as a side note here, the pH of acetic acid at 0.25% concentration is 2.8 to 3.4. So now looking at this table here, between the Vashe and Anasept, which would favor the growth of Pseudomonas, Staphylococcus, E. coli, and Enterococcus faecalis? Looks like you know the answer, right? So now, I would like to talk a little bit about the acetic acid. Someone would argue or would say that since the pH of this solution is very low at 2.8 to 3.4, wouldn't it be an appropriate antimicrobial that we should use frequently in the um, on the basis of dropping the pH of the wound, especially if the wound is stuck in the chronic inflammatory phase of healing. So, uh, what I can tell you is there might be a truth about the effectivity of this of acetic acid as antimicrobial agent, but I still have to say I study with a great level of validity about its being non-cytotoxic at even at the lowest concentration, effective to kill bacteria. So unfortunately, the literature about acetic acid is still inconclusive as of this time. So if you ask me if do I use it, so my answer is yes. Okay, but the way I use it is a little bit different. I do not use it as a regular cleansing agent in my practice. So I'd reach for the acetic acid to like a form of a big gun when I see a greenish discharge on the wound. So um, you know that the greenish discharge is usually um, an indication of a Pseudomonas infection because the Pseudomonas has demonstrated its ability to produce that greenish pigment, right? So, however, even its effectivity for Pseudomonas is also controversial in the literature. But I'd say that in my experience, as soon as I see a greenish discharge, I cleanse the wound with acetic acid, and usually it takes 1 to 2 times, and the greenish discharge would go away, and then the wound will start healing again. So, anyway, going back to our topic, although the concentration of sodium hypochlorite, which is the Anasept, has been arguably as non-cytotoxic, still my issue in this solution is still go around the high pH. So, as the result of these two papers that I have tabulated here, um, shows a correlation of a bacterial growth to an increasing pH. So, let's continue. So, what is really the problem in chronic wounds? So, the chronic wounds have high level of bioburden. So we have the planktonic bacteria, and we also have the bacteria which are attached to the surface in biofilm. So the bioburden drives the wound base to a high pH of 8.5. If you recall on my first video, I mentioned that the production of hypochlorous acid requires a low pH environment because protons are required for the production of hypochlorous acid. So therefore, due to high level of bioburden in chronic wounds that drive the wound base to a high pH, there is an impaired production of hypochlorous acid and a subsequent decreased ability to eradicate bacteria. So, by the way, at this point, I feel that I need to make a separate video on biofilm so we can understand this better. So, if you look at this illustration here, you see that there's a see this free floating bacteria. We call this the planktonic bacteria. And you also have this bacteria which are attached to the surface in biofilm. If you recall, in your pharmacology class, antibiotic can only be effective in killing free floating bacteria like the planktonic bacteria, like you can see in this illustration. Okay, so the goal then of treatment in chronic wound, which are stuck in the chronic inflammatory phase of healing, would be to decrease the bioburden and to drop the pH of the wound base. So, ladies and gentlemen, so this graph shows you the dissociation curve of hypochlorous acid in a solution. So, look at the pKa of hypochlorous acid is 7.5. So, as you increase the pH, like what's happening in a hypochlorite solution, the pH of 10, okay, if you look at this graph, the concentration of hypochlorous acid is zero, nada, none. So because hypochlorous acid is already deprotonated to the hypochlorite acid side. So I want to mention also that the hypochlorous oxidation potential is twice as the hypochlorite anion. So its ability to kill bacteria is twice as effective as the hypochlorite anion. So moving on, the therapeutic index, or we call it TI, is referred as the therapeutic ratio, which is defined as the quantitative measurement of the relative safety of a drug. So in pharmacology, a ratio that compares the blood concentration at which a drug becomes toxic and the concentration at which the drug is effective. So in here, the larger the therapeutic index, okay, the safer the solution is. If the therapeutic index is small, like the difference between the two concentration is very small, the solution must be dosed carefully and the person receiving the solution should be monitored closely for any sign of toxicity. in this graph that is being presented in this slide, um, you would see that the relative therapeutic index of hypochlorous acid when they're applied for these three organisms are very large. So the higher the therapeutic index, the safer the test article would be. So moving on, the time to kill is an in vitro measure of how fast a given antimicrobial solution could kill a test bacteria. So in this study, they compared hypochlorous acid, the hypochlorite, and the hydrogen peroxide. Um, as far as their ability, or I mean how fast they could kill a test bacteria. And you would see in this table that hypochlorous acid is really a fast acting solution with regards to its um, ability to kill uh, a microorganism as compared to the rest of the solutions that is being studied in this uh, experiment. Okay, so the by the way, the cytotoxicity measured in a cell proliferation assay is expressed as the concentration that reduces the cell number by 50% of vehicle treated control. Okay, now if you look at the other side of this slide, we have what we call the MBC, or we call that the minimum bacterial concentration, which is the lowest concentration of antimicrobial agent required to kill a particular organism. So let me repeat that. The MBC, or the minimum bacterial concentration, is the lowest concentration of an antibacterial agent required to kill a particular bacterium. So between the two solutions, the hypochlorite and hypochlorous, okay, you see that the hypochlorous has lower numbers, and you want these numbers to be low because as you increase this number, you the issue of cytotoxicity will come into the picture. So the higher this number, the most likely that the solution is cytotoxic. So you want this to be low, and as depicted in this table, hypochlorous acid has lower MBC compared to hypochlorite solution. So in the left side of your slide, researchers are trying to find out the cell viability after exposure to the Vashe into the Anasept solution after 6 hours of exposure. And it has been demonstrated that the cell viability is 22 to 42% with Anasept versus 68 to 82% cell viability with a Vashe solution, meaning to say that there are more viable cells being demonstrated after 6 hours of exposure to the Vashe solution as opposed to when they're exposed to the Anasept solution. Okay, so now on the right side of this slide, look at this study by Zakaria et al. So let me just tell you briefly about the biofilm. It's one of the reasons why a wound is stuck in the chronic inflammatory phase is that because of the presence of biofilm. It has been demonstrated in a lot of clinical studies that the biofilm actually expressed certain DNA that can easily be recognized by our immune system. And once they are recognized, it makes our immune system to keep producing all those proteolytic enzyme like the proteases and whatnot. And these are detrimental for the production of granulation tissue. So because they continually degrading the matrix, the extracellular matrix. So this biofilm, like what I said, expresses certain DNA that continually stimulating the immune system to produce this detrimental enzymes. So uh, when you reduce the amount of biofilm, or if you eradicate biofilm by the use of effective and uh, efficient, I would say effective and efficient solution like the Vashe that being used in this study, you would decrease the inflammatory response that is usually um, uh, found in a chronic wound that is stocked in a chronic inflammatory phase of healing. Remember that our goal in wound healing is to move the wound from this phase to the next phase of healing. Okay, so I hope that is clear. So I just want to show you this abstract about the in vitro um, microbicidal antibioform in cytotoxic effects of different commercial antiseptics. So in vitro, a variety of antiseptic were analyzed to see their effectiveness against biofilm formation and removal and the cytotoxicity of these agents to human fibroblasts. So they found out that chlorine-releasing agents exhibited immediate antibiofilm effects in the short term with lesser toxicity than agents prepared from more stable compounds such as biguanide. So interestingly, hypochlorous acid was effective in preventing biofilm formation within a short period of time and showed a virtually no toxicity. This is according to this study. Okay, so one of my favorite journals in wound care is this journal, the Today's Wound Clinic, and this was published. This is a work of Robson, and I like this two graph here showing how hypochlorous acid um, could dramatically and abruptly decrease both the number of bacteria and also disrupting the polysaccharide component that is found in biofilm. So they're saying that it's maybe a very good solution to assist a hard to heal wound because of its effect on the biofilm. Okay, so let's wrap up. So, as we're wrapping up with our discussion, let me just tell you that in my cabinet of wound cleansers, I only have four uh, cleansers in there, or four solutions in there. First is the normal saline. Second is the Vashe solution. Third is the acetic acid. And the third is the Dakin solution. So why normal saline? I still use normal saline for some purposes like normal irrigation, normal cleansing, but always remember that normal saline cannot decrease the bioburden in the wound, and it cannot disrupt the biofilm. It cannot help in the prevention of the formation of biofilm, especially in acute wounds. Okay, if you remember, I mentioned in the first slide that studies have demonstrated that a biofilm can be reformed or can be formed in acute wounds 3 days after a surgical debridement or 3 days after after a surgical procedure. So now, next is the Vash solution. So my strategy is that I usually soak the wound. So I saturate sterile gauze with a Vash solution, and I place it directly on top of the wound, and also insert that or fill the undermining of there's a tunnel. I fill the tunnel with the saturated gauze, and I will let it stay for 5 minutes. So according to the study, the effect is immediate, but I think I believe that the longer would it stay there, the penetration will be better, and I believe that more exposure is better than a shorter exposure. And with that regard, I always tell my patient that when you do this at home, do it for 10 minutes because they have more time. So I see like 14 to 16 patients in my shift. So I don't have a lot of time waiting for 10 minutes. That's the reason why I only do it for 5 minutes. So, and also let me mention my style is I do not pat dry because I believe that is since it's compatible to our body. So I believe that it can stay there and I don't have to pat it dry. And I use Vash solution in conjunction with other antimicrobial dressings or topicals. And one of the things that I like about this product is that it will not interfere with the enzymatic activity of the collagenase if I have to use Santel. Anyway, why acetic acid? I think I already told you earlier that I use this to manage greenish discoloration. So in my order, it says acetic acid as needed for greenish discoloration of the discharge or the exudates coming out from the wound. And I use Dakin solution for odor management. I have found out, and I can uh, probably this is still anecdotal, and anecdotal is not a good evidence. However, I can tell you that Dakin solution, in my experience, is a very good uh, product to manage odor. So if I have lately, I have this gentleman that I saw, and you could really, 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 really smell the foul odor of the wound, even without without um, uh, opening or removing the dressing. You can already smell it. And I tried some other stuff like the topical metronidazole, but it didn't work. The only thing that helped with the odor is the Dickens solution, but I don't use it for a regular as a regular cleansing agent because, like what we said, it's very cytotoxic. And that's it. Let me see if I can summarize this presentation.